I just like to take this opportunity to thanks everyone for coming down. I hope you enjoy the presentation. I've only been at Sunshine Heart for 6 months now, so we're just beginning to accumulate some hemodynamic data, which everybody keeps asking for. When I first started at Sunshine, I asked Dave, how much hemodynamic data do we have? And he said, that's why we hired you. So I'd just like to start off. And by the way, I put this talk together as a completely interactive talk. There's a lot of weird stuff in here, as you'll see from the title. The weirder the title, the less data you typically have. So, so there'll be a lot of forward-looking statements here. And they're part of the management, i.e. Dave. Various factors, including collecting more data, which is always useful, could change some of the content. Fred? So I'd like to start off by talking about kangaroos, waves, reservoirs, and reflexes. Next. So I said it was interactive, so I have a quiz. So this is a very simple model of the circulation here. This is your heart, and then the periphery, which is just a bunch of tubing. The problem is this will never work. Why? Can anybody tell me why? Sorry?
You need directional flow.
Yeah, there's a valve here, so there's unique. Yeah, but you'll never get flow out of the system. Anybody tell me why? Sorry? Yes, thank you. One person saves me every time. Hit next. You actually need a reservoir in the system to have flow, so you can drain blood or water from here into the pump and keep the flow going. And when I was in graduate school, this is the way I was taught basically, and I direct quote from my advisor. The heart is just a stupid pump. All its job is to keep this reservoir full so that it continuously drains back towards the heart, and then the heart pumps it back out into the arterial system. And basically, there were a lot of discussions this morning on patients being too sick. Devices like CPulse do not do anything to the heart. The device principally acts really on this reservoir and on modulating some of the tubing, and I'll show you some data on that. This is why we need a relatively preserved amount of cardiac function. The trick is how much. From my perspective, the higher the better, EF-wise at least, which is not always the best measure. Next. So everybody's heard counterpulsation is based on 3 principles, not so much the third one, but you reduce afterload, you augment diastolic pressure with the hope of increasing coronary perfusion, and it basically acts as a secondary pulsatile heart. So while the heart rests, the device, the CPulse or intra-aortic balloon pump, is pumping during this period. So it's like 2 hearts basically in series, just alternating in timing. And that's the end of my talk, actually. Thanks for that's how it works. Let's go ahead. Now, as artificial as it may seem, counterpulsation is actually a physiologic phenomenon. In the mid-60s, of course, this had to be done in Australia because they did catheterizations in kangaroos. And when you put a catheter inside a kangaroo, this is what the waveform looks like close to the heart in the aorta. You see this very prominent wave in diastole, and then this is the systolic portion. And you can see the flow waveforms here that they've recorded simultaneously. It looks exactly just like the human flow waveform. So there's nothing peculiar about the flow waveform itself that's giving rise to this waveform. This is an intra-aortic balloon pump from a patient. You can see it basically just mimics what the kangaroo waveform does. What you're seeing here with the kangaroo is this exaggerated, and this is the part of the talk I talk about waves, is the wave that gets put out by the heart. The kangaroo's got this very long muscular tail, and this wave travels down that tail and basically reflects back up. So it's like you were having a jumping rope, and you send a wave down that rope, part of that wave's going to come back. If you narrow that tube that wave is going down, a lot of it is going to be coming back towards the heart. And that's what you're seeing here. And the kangaroo, again, is exaggerated because of the long muscular tail. The arterial system is designed to naturally have these waves because when the heart isn't beating, this wave comes back, you can see during diastole, and it does exactly what counterpulsation does. It helps perfuse the coronaries. In disease states, the arterial system loses some of its buffering ability, and this wave now doesn't come back in diastole anymore, but now starts coming back during systole. So you're not only losing this boost in diastole, you're also adding this boost in systole, and hence you're loading the heart. Next. Now, anybody that's sort of studied arterial hemodynamics, the aorta is an amazingly engineered structure. Again, hearts are stupid, but aortas are really smart. The aorta really has two functions. One is the proximal portion particularly, you can see here, acts as like a compliant chamber, a buffer. And what this does is it accepts the stroke volume from the heart, and when the heart isn't beating, it now squeezes the blood out to the periphery. If you didn't have this, when the heart stopped beating, the flow would fall down to zero, and it would truly be pulsatile flow. So the proximal portion takes this pulsatile flow and does its best to convert that into a steady flow. The other part of the aorta, which is downstream here, is designed to maximize these reflections that we talked about earlier to boost the diastolic portion. All these matching of these vessels downstream are very precisely matched so that this reflected wave comes back during diastole. It's really a remarkable system considering the thousands of vessels and the branching points that are happening. But again, during disease states, both you start losing this compliance and you start losing this optimal matching downstream. Next. As studies now are being done focusing on these different parts of the aorta, they're actually linked to outcomes in heart failure patients. You can see remodeling of the root with taking into account all the other risk factors is actually a very, very important risk factor for heart failure coming out of Framingham in 2013. And more recently, the distensibility of the proximal aorta, conveniently where we put our cuff, by the way, from the MESA study is an independent predictor of all-cause mortality and incident cardiovascular events. Really, really powerful statement. All-cause mortality linked to very, very small part of the aorta. I forgot to add that small part of the aorta actually, which acts as a buffer, about 70% of the buffering action of the arterial system is in that small portion. And that's why I really got excited about a therapy like the C-Pulse, because nothing is ever targeted. You heard of all these de-stiffening strategies right now. This is where those medications primarily are trying to target, is that the proximal part of the aorta. So it's exciting to be able to put something on there and to modulate it or squeeze it, expand it to affect its stiffness. Again, you can see familiar with where the balloon is placed. But if you go back to studies back in the 60s and 70s, you see there were several, people already knew this, that the closer you got to the aortic valve, the more effective the counterpulsation technique really is, both at reducing afterload and in perfusing the coronaries. And again, it's because you're modulating the compliance. So if you think about it like a bellows for your fireplace, this is what that compliance portion or counterpulsation does. It really acts like a bellows, where it blows air out during diastole, and then when you pull open the bellows, it sucks that air back in. In the case of counterpulsation, that sucking action is to what we call reducing afterload. It potentially sucks blood out of the heart. Next. You can just click on the left one. There's two videos here. You can just see how, you can see the C-pulse squeezing. This is the root of the aorta here. You can see, even though it's a relatively small cuff and the volumes are relatively small compared to anti-aortic balloon pump, you can see it has a quite profound effect on squeezing on the proximal part of the aorta. And not only just squeezing it, but when this thing expands, you can imagine now how quickly that pressure is lowered in the root of the aorta. Can we go back one? Yeah. And there's a nice fancier 3D image here that you could really see again. This is courtesy of Dr. Bunau in Erlangen, Germany, who provided this image. Very, very time-consuming 3D CT reconstruction, but again, really fantastic image to see how effective that cuff really is. Fred thought he was just going to sit back and relax during this talk. So again, we've had the opportunity to go out, and the other unique aspect of this device from a physiologist perspective is you can turn the device on and off. And so the patient serves as his own control if you want to make hemodynamic measurements. Very, very convenient. And if, obviously the patient doesn't destabilize when you turn the device off. This was a cath lab from a patient who was out 4 months, and you could see during the off, he was paced at 80, so his heart rate is fixed. You could see the PA pressure, CVP, and the wedge, the cardiac output thermodilution, and you could see the deltas in when we turn the device back on. Interestingly, the wedge fell a substantial amount, which is probably driving the PA pressure, but you could see the deltas in cardiac output that we typically get. And they're somewhere between the range of about 30%, which is why, again, it doesn't target the heart. It's not an LVAD. It will not restore cardiac output. It's a supplement. It relies on the heart itself. Thank you. We also had the opportunity, we acquired some SphygmoCor devices from Atcor, which basically allows you to obtain a waveform at the wrist. It's like a radio, it's like having an art line in the patient, but this is completely non-invasive. You put on the patient's wrist. It gives you a nice waveform. And the unique features of this device is it gives you a radial waveform, and it does some fancy mathematics to derive a central waveform, which is as if you'd put a catheter up on the root of the aorta, and then from that you can make some of these measurements. And we talked about earlier about wave reflections in the aorta, which is used to assess with that device. But you could see the effect of the wave reflection coming back in systole here. Someone in this study here, this is an LV tracing, but the arterial one would be similar. But if you just slightly compress the aorta and create an artificial reflection, you could see that in late systole, this pressure rising. This has a profound effect on flow. So a lot of the afterloading effects really come from this late systolic wave, and it has hemodynamic effects in that it affects the cardiac output. And this is a completely normal heart. So we had this opportunity to do this in patients as part of the programming of the CPulse. The field team had a bunch of these devices. I was torturing them for a few weeks. David especially led the effort and went out and collected these waveforms. But again, you could see this is a patient here off the radial waveform, and then the mathematical calculation to derive the central waveform. There's that wave reflection. See, it's not like the kangaroo that wave would be here normally. You could see it peaking here, this little hat-type structure. When we turn the CPulse on, you can see now, almost immediately, you can actually see it in the radial waveform, even before the calculation. You can see how sharp the triangular wave is here versus this rounded shoulder. This rounded shoulder is that wave in the periphery that is coming back and now is contributing to the pressure during systole. You can see the central pressure here now. That hat now is virtually gone. And this is the augmentation index. You can see the value here of off, and then went down to nearly 8% when we turned it back on. And this other secondary pulse is obviously the CPulse squeezing during diastole. Next. We did 5 consecutive patients, and we saw very consistent results. This is that augmentation index. There was an absolute 20-point reduction in the augmentation index, which is a huge effect. It's like giving hydralazine or a nitrate to a patient in reducing the augmentation index. You can see the values here are highly significant. And we're submitting this now to the American Heart Association. So we saw this consistently in every patient that we've studied up to that point. Now, another part of that late systolic wave that is coming back to the heart, and this is really just in terms of quantifying augmentation index, but why is this important? How is this relevant to the heart? Is because it contributes to wall stress. Having this late load, and as everyone knows, wall stress is a key indicator of remodeling in the heart. Elevated wall stress leads to remodeling, is one of the key indices in predicting myocardial oxygen consumption. And you can see here in a normal ventricle, when it shortens here during ejection, the wall stress is actually highest at the onset of ejection. And then as the ventricle begins to shorten and the wall thickens, this reduces the wall stress because the thickening of the LV during ejection. You can see the wall stress is falling during ejection. in heart disease, when you have a thin wall, the wall stresses are high to begin with, but you could see that they stay elevated during the entire ejection period. And this is further compounded, the wall stress, by this reflected wave coming back. So there's a tremendous load being placed on systolic heart failure hearts, even though their blood pressures are low. And then you can see how wall stress is also related to the velocity of circumferential shortening here, how quickly the heart can basically shorten. You can see normal and heart failure. This is just blown up here. Next. And there was a paper published in 2005 with some of the initial patients in the CPULSE. And you could see again, doing the on-off of the one-on-one counterpulsation, you could see a large drop in that wall stress with the CPULSE, again, because it's unloading the heart. And these are all the patients here at baseline. And then not only was there a reduction in wall stress, but you could see they're also moving up to the left as well, so that circumferential velocity is increasing as well, as you would expect. And this is what is referred to as improving cardiac performance. It looks like the heart is more vigorous. It's not an inotropic effect. This doesn't cost any oxygen to do that. It's just simply reducing that load that the heart is seeing late during ejection. And again, if you look at the other part of counterpulsation, obviously myocardial oxygen consumption is very important in these patients. Irrespective, I think, of whether they're classified as ischemic or non-ischemic, I think all these patients suffer from some level of ischemia. Even the HFpEF patients are probably ischemic as well to some degree. But again, I think as all of you know, the heart pretty much extracts all the oxygen that it gets. And so the only way of increasing O2 consumption is actually increasing coronary perfusion, and hence the counterpulsation effect. Next. And again, going back to some of the waveforms from the patients, and you could see when the device is off during diastole, when the coronaries get perfused, you could see how quickly the pressure drops, because again, the system is stiff, and this counterpulsation, which is again squeezing of the aorta, boosts blood pressure and keeps the pressure up during the diastolic phase until the next cycle hits. And you can see the decay here at the central waveform versus this one. We had the opportunity to do one animal study so far where we put a flow probe on the coronary artery. It's a normal pig. It wasn't in heart failure. The red here is CPULSE. The blue is with the device off. You can see here diastole, systole, diastole. You can see when the device is off, obviously there's a huge boost during diastole in coronary flow. Very, very large value, actually, given the volume of the balloon. But what's interesting is that if you look at when it was off, there's actually retrograde flow happening in the coronaries because the blood pressure was relatively low during the anesthesia. And this was completely reversed with the CPULSE. There was no flow reversal happening here. And again, this is different from the intra-aortic balloon pump, which is why I think the literature is so variable on coronary blood flow, myocardial oxygen consumption, is when you have a balloon down here and you're inflating it, part of the energy goes down here, part of it is also going up the subclavian, but this arch here is very effective of trying to trap some of this pressure coming back. And there's actually very little of that balloon, the counterpulsation balloon down here, actually making it back into the coronaries. Now, why did I go through all that effort of saying the diastolic pressure is elevated when it's obvious that that's what counterpulsation does, is it elevates diastolic pressure? There's some recent studies coming out right now, clinical studies by Davies Group at University College London, where they're taking flow wires, putting them in coronaries of patients, and measuring flow velocity here, and pressure. And if you take the product of these two, basically, it's a simple calculation, but it's being used more often now in hemodynamics. The product of these two provides the power or energy of that system. You can see here for the coronary system, there's a very large energy front traveling down the coronaries when the heart begins to eject, again, as you would expect, before the heart actually compresses the coronaries. There's also another one right at aortic valve closure. As you would expect, the coronary blood flow, that's when it's increasing. The interesting part of this study was these waves are going in the opposite direction. This one's up. There's a reason why it's up and down here. Down is that the coronaries it appears, are filled not from the pressure in the aorta pushing blood flow down into the coronaries, is that when the heart contracts and squeezes the coronaries, and then when it relaxes in diastole, the coronaries spring open and actually suck blood out of the aorta. And that's why having that reservoir there and elevating the diastolic pressure by counterpulsation is important. You allow the coronaries basically to take as much blood as they need. It's a self-regulating system. It's not the push of blood that is happening there. It's the coronaries actually are able to suck blood out of the root of the aorta. I told you it was going to get weird. Some very, very recent data is coming in from the OPTION study in Europe. This is not paired data in patients. This is all the data we have out to month 6. You can see that there's a fairly large increase in ejection fraction in these patients that we're seeing. And a lot of this, again, if you look at some of the theory of the unloading and potential myocardial coronary blood flow, this EF effect is predominantly driven by the end-systolic volume. The end-diastolic volume, we really haven't seen any changes out to 6 months. But again, as you drop this load, the heart is able to eject more, like it is, like you saw with those wall stress plots, and reduce the end-systolic volume. Actually, quite dramatic reduction. Now, interestingly, this is from feasibility. We haven't looked at the options data yet. Again, as Dr. Abraham described, feasibility was only a 21-patient study, and it was primarily, again, it was a feasibility study, so they weren't really looking at efficacy measures. But echoes were taken, and there were paired data out to 6 months of assessing the septal E to E prime. As many of you know, is an index of filling pressures or diastolic function. And you could see that, again, this is FDA mandated where there was an improvement or no improvement. That's why it's coded like this. But you could see that for most of the patients are seeing really large drops. Hemodynamically, these are huge drops in the E to E prime at 6 months. And systolic heart failure hearts have as much diastolic dysfunction as the preserved hearts that we call diastolic heart failure. But it's important to realize that improving the systolic function, like I said, like in the previous patients, where the EF goes up, the end systolic volume is allowed to get small. When the heart shortens like that to smaller volumes, it's able to use some of that energy and spring back up and again suck blood out from that reservoir. And just to illustrate this, physiologists have a way of making bizarre points, but next, let's hit the space bar. One more. One more. One more. One more. If you can click on the top one. This is a movie from Dr. Fritz Myler from Amsterdam. I got this from Bill Little, actually. But you can see he cut out a rat heart and attached it to a boat. And the heart is able to propel the boat. So it's not hooked up to any circulation. But this is an extreme afterload reduction. Basically, there's no arterial system. So there's zero afterload here. And the heart can eject vigorously, even though it's ischemic, taken out of the rat. It's actually shortening to very low volumes, and then when it expands, it sucks water in from the tank, and then it squeezes it out to the aorta and propels this boat. Fred, can you play the bottom one, please? As again, very motivated physiologist had a camera in the tank as well, so you could actually see. So the systolic function in and of itself will improve the filling properties, the filling pressures, and the diastolic function of the heart. This is available. Most of these slides are available to anyone if they want. I'll show you my email afterwards if you'd like a copy. Now, I'm almost done. I know it's close to lunch. There's some interesting effects that we've been seeing. I used to work in neural control of the circulation before I came to Sunshine. I was at CVRX for 8 years looking at baroreflexes. To me, one of the potential aspects is in the C-pulse is the pulse. And I know it's very controversial now with LVADs. They're non-pulsatile versus pulsatile. People are still going back and forth. But one aspect of counterpulsation is you actually provide a pulse, irrespective of all the hemodynamic effects. And you can see here, this is a central aortic pressure tracing. And this is recording, there's microelectrodes on the nerve coming from the baroreceptors on the aortic arch. And it's right where the cuff is, actually, where the aortic baroreceptors are located. There's two primary baroreceptors. There's one's on the arch and one's on the carotid sinus. But you can see here the baroreceptor firing right at the onset of ejection. They keep firing, and then there's a small burst. You can see these separate fibers here are firing during the end of diastole, and then they relatively go silent during the diastolic period. Now, it's very interesting that counterpulsation is timed right in the most sensitive regions of where the baroreceptors are actually, the brain is tuning these receptors to listen to during the cardiac cycle. Here, when you unload, when we deflate the balloon or the intra-aortic balloon pump, and here, where we inflate the balloon. Next. So again, just you can see here the nervous structures that are on the arch of the aorta and the baroreceptors. Now, what's interesting still, obviously, it's very difficult to tease out because people have also described reflex effects with intra-aortic balloon counterpulsation. So it's not clear how much of any potential reflex effects may be this direct compression on the aorta from a balloon on it, or from just creating this pulse, which the balloon does, that in a system with heart failure where the heart is weak is not giving that enough pressure to activate those receptors effectively. So who cares? Well, there's probably every flavor of neuromodulation right now. Every company, whether it's renal denervation or vagal nerve stimulation or spinal cord stimulation or barostim, baroreflex activation, is developing some form of neuromodulation therapy. The NIH has invested $300 million into looking at further defining the autonomic nervous system and signaling between primarily the baroreceptors and to the periphery. Because if you look at on the left side here, the drivers of sympathetic outflow from the brain, really the major brake of sympathetic outflow are the baroreceptors in the arch and the sinus. They provide a negative input to the brain to slow down sympathetic activity and enhance parasympathetic activity. And you can see some of the negative effects with elevated sympathetic activity, which you have in hypertension, in heart failure, in COPD. Virtually every disorder has some component of sympathetic activation. And you can see some of the effects here. And of course, a lot of the drugs that have been developed are really targeting some of these outflow of the sympathetic nervous system. Next. So I come back to that reservoir model from the beginning. So it's a little more complicated than just one reservoir. It's actually two reservoirs that the system regulates. And if you didn't have these two reservoirs, you couldn't exercise, basically. So when you start exercising or high performance, what the system actually does is shift volume from this reservoir up to the heart to keep it filled at the very high heart rates. Because if you take a heart or a patient and you pace them at that heart rate that they're exercising at, their cardiac output would actually go down. And these adjustments are made by the baroreflexes, by the sympathetic nervous system. So it's a system that is it's able to modulate all aspects of the peripheral circulation. Oh, I'll skip that one. Everybody knows that. Now, one way of measuring sympathetic activity, you can do this in patients, is to put this little needle here. There's a nerve running down, the peroneal nerve running down the lake here. You put a needle in it with an amplifier, and you see these bursts. And these bursts are right when the heart is ejecting, like I showed you before with those waveforms. These bursts are all timed to cardiac ejection. And people count the bursts and count the area of the bursts to show whether there's enhanced sympathetic activity or reduced sympathetic activity. Next. It's a study by Ben Levine that was published in 2013 out of UT Southwestern, really, really phenomenal work, and has really, I think, reignited this debate about continuous flow LVADs. Is if you look at control patients and then heart failure patients, ambulatory class 4 patients that have LVADs, he had enough of his center where they could do a pulsatile and non-pulsatile comparison. You could see the pulsatile LVADs restored that sympathetic, those bursts, to near control level. The non-pulsatile LVADs had still this elevated sympathetic activity, this increased resistance, this drive to the kidneys to retain water was still there despite normal hemodynamics in the non-pulsatile LVAD. In fact, the hemodynamics, if you look at this paper, between the two groups are virtually identical. Their filling pressures were identical, their CVPs were identical, their cardiac outputs virtually identical. Muscle sympathetic nerve activity, modulation of the nervous system, very, very different. There was a presentation as ISHLT a couple of weeks ago, again from the same lab, where they're now, Thoratec has been looking at some of this data, and what they're trying to do is they're putting algorithms in their devices to modulate the RPM. So they'll slow it down, they'll ramp it up, they'll slow it down, and with the hopes of trying to create some kind of artificial pulse with a continuous flow device. And you can see here when they slow it down and actually create a bit of a pulse, I'm sure the heart is also ejecting as well when they slow that pulse down, you can see what happens to sympathetic nerve activity. It almost gets shut off because it's that pulse is stimulating the baroreflexes. And you can see here a relatively nice correlation between the pulse pressure, the pulse that is stimulating those receptors, and the muscle sympathetic nerve activity. And then when they turn the speed up again, you can see now that sympathetic activity increases because they're not being stretched anymore. What is really deranged about this, and as a physiologist, I find this completely deranged. So if you look at the pressure here and here, typically when your blood pressure falls, your sympathetic activity increases to constrict your vessels to get your blood pressure up. This system has completely reversed that. The blood pressure here is actually falling, and the sympathetic nerve activity is falling as well. It's because non-pulsatile LVADs introduce a very, very high level of sympathetic activation. And any stretch that you can provide to the baroreflex is actually turning that down a little bit. There was another study looking at, we talked about the heart regulating cardiac output, which it doesn't. It's all about the circuit. This was an LVAD patient, again, at measuring the cardiac output during different levels of exercise. And what they did was they ramped up the LVAD to different RPMs during the exercise time. And you could see that whether they ramped it up or they kept it at a constant speed, the cardiac output the patients were able to achieve was identical. So it's not just driving more flow through the system. It's somehow you need to be able to modulate this, like counterpulsation potentially could modulate and bring back some of these receptors to control some of the peripheral circulation. Some interesting studies out of Japan from Kenji Tsunagawa's lab where they repeated the old Guyton studies where they ablated all the baroreflexes and measured arterial pressure, but this time they also measured left atrial pressure as well in these rats. And you could see, as Guyton showed again in the 50s, you could see if you look at the standard deviation of arterial pressure, you could see it's much higher in rats that have been denervated. The mean pressure isn't the same, but you just get this fluctuation in pressure. And then this is where this whole field of, well, the chronic effects of baroreflex aren't important because the blood pressure doesn't change. If you look at what's happening in the heart and you measure the left atrial pressure in these denervated rats, you could see that for a substantial part of the day, over 1,000 seconds, because they were recording continuously, you could see these rats are in heart failure, the definition of heart failure. The left atrial pressure is greater than 18. And it's because the baroreflexes, part of their job is to manage volume. Those reservoirs, they shift blood back and forth between the reservoirs and the heart. And when you lose this control, you could see you could potentially end up in a heart failure type state. So why did I say that? Well, we had a patient on CPulse that had a CardioMEMS sensor implanted. And the device was actually deactivated. The patient still has the balloon intact. The pill was taken out. And you could see during the course here of PA pressure measurements, this is systolic, mean, and diastolic. It's relatively stable over this whole period. This dip here. This is actually timed very well with ramping up of the therapy with the CPulse. But at this point, the CPulse was turned off. Now you could see what happens. The pressure all of a sudden starts oscillating after that. So it's very intriguing that it looks a lot like that rat. I won't tell the patient they look like the rat hemodynamics, but again, it's indicative of something that potentially baroreceptors could have been stimulated, and now that stimulation is lost when the device is off. And you get this shifting of fluid or resistance. Again, this is the PA, which is interesting. It's on the right side, where these pressures now are oscillating. So Dory did a great job of following up with that. This was submitted as an abstract to Heart Failure Society. And we're gonna look at a longer duration of follow-up and see if when these pressures stabilize, if they stabilize at all. Next. 3 more slides, I think. That animal lab that we did, it was the same animal again, where again a normal pig, where we put a flow probe on the renal artery and measure renal blood flow, because again, we're thinking if there are some potential reflex effects, this has a profound effect on the kidneys. This whole renal denervation concept is all about. So if you look at the off renal blood flow off here in the dashed red, and then we turn the C-pulse on. So this is the diastolic. This is when the cuff inflates here. As you would expect, it's increasing flow. But it's also increasing the peak systolic flow, and the diastolic flow is also lower than it is with off. And we had studied this years ago. This is a signature of reflex effects on the renal circulation. It's believed that when you stimulate baroreflexes and the flow starts oscillating like this, it stimulates the renal circulation to not release renin. There's some kind of flow sensor in the renal circulation. The overall flow changes very little, but this pattern is very characteristic of the renal bed and perhaps suppression of renin. Next. This was from a device in the 60s that Medtronic had developed that actually put electrodes on the carotid sinus nerve and electrically activated the baroreflex. And they also measured renal blood flow, and you could see what happened here. When you stimulate baroreflexes, what happens to renal blood flow. Again, the same type of oscillation pattern emerges. So I think from my perspective, how do I see what is the goal of C-pulse therapy? And I think this really it touches based on hopefully some of the mechanisms that we've shown here. There's obviously this unloading effect, which is a cascade. It's an effect of this cascade, this neurohormonal stimulation, volume retention, that increasing afterload. So this is kind of obvious, but it would be interesting if it was also targeting some of the upstream pathways of neurohormonal modulation. And I think, again, it's important that it supports the heart. It doesn't do anything to the heart. It's not going to increase your cardiac output. It just optimizes the conditions for the heart to eject now into the arterial system. And hopefully, it'll stabilize the heart. It'll normalize the circulation. And I think even better, it'll allow the meds to actually start working, because these medications, obviously, beta blockers, ACE inhibitors, are very effective. And as I've heard today, a lot of the patients become intolerant to those medications. So being able to resensitize that and stabilize the patient, I think really is the ultimate goal of this. And hopefully when we develop a fully implantable system, it's something that will allow us to target healthier patients before they start reaching that border zone. And the last slide, one more slide. There was a lot of talk about milrinone here in the room. Milrinone is a very interesting drug. We studied this in the lab about 20 years ago in Dave Cass's lab, published in Circulation, looking at positive inotropes and calcium sensitizers. Milrinone at low doses is actually a very potent vasodilator, extremely potent. It acts on the venous system. You could see here, this was a pacing heart failure dog. This is in control. And then after milrinone here. So you could see the venodilation, the preload falls, the wedge falls, as you've probably seen in your patients. If you looked at ejection fraction, you could look at ejection fraction, it probably goes up because the stroke volume doesn't change, but the end diastolic volume has fallen. So EF looks like it's gone up. The contractility has gone up here because, again, it has positive inotropic effects to maintain the stroke volume. But if you look at from control, there's very little change in cardiac output. And hence, low-dose milrinone, which is here, causes very little change in myocardial oxygen consumption, which is why people have been using it. If you restore the volume back to here, same animal, we just gave him back the volume to increase his preload back to control, and now increase the stroke volume so that you do get a cardiac output effect, a true positive inotrope effect of increasing cardiac output, you could see what happens to the myocardial oxygen consumption. It goes up dramatically, almost doubles actually. So it's tricky. I mean, we can only assess this by having pressure volume loops in animals, but you could see with positive inotropes how the picture can become very, very complicated. Again, I'm not a clinician, but it's just it's interesting that 20 years ago nobody used this. people saw this, and now it's, I hear it more and more as we go out to sites. And again, the discussion earlier, I think, really really shows how prevalent it's being used again. And on that, I'd like to thank you for your attention.